introduce yourself. Okie dokie, go ahead and consent to that if you don't mind. So introduce yourself in the chat if you'd like. In the chat features down here below, and you can select all panelists and attendees if you want the message to go out to everyone. If you want to send a private note just to the folks on the panel, those of us you can see, you can select all panelists. Please also put questions in the Q&A. If you put them in the chat, we might miss them. So go ahead and put them in the Q&A so we know to get back to them at the end of everyone's presentations. Let's see, now that my chat box is blocking some things. So I think that's it on this slide. Okay, okay, there we go. Other housekeeping notes. Feel free to upvote questions in the Q&A box so we know which issues you want to make sure get heard. Also, you can submit questions anonymously if you so choose. In an effort to get through as many questions as possible at the end, we're going to ask our wonderful panelists to limit responses to just a few minutes. And yes, we will be sharing the slides and recording after this, so fear not. You don't have to furiously take notes or anything. We will send this out. Okay, next slide, please. I want to last acknowledge that though we have partners on your screen today who are doing stellar work, they are not the only folks in Missouri, clearly, who are working with pregnant and postpartum people who use drugs. So we want to give a special thank you and shout out to other women and children C-STAR programs, publicly funded substance use treatment programs who specialize in treating women and children, federally qualified health centers all over the state, JAMA Birth Village, the Care Clinic, Wish Clinic, and I'm sure there are many others that just might not be on our radar, but thank you all. And thanks again to our presenters today. I will now kick it over to Dr. Candice Woolfolk, who will be moderating today's session. Thank you all.
Hello, as Rachel said, I'm Dr. Candice Woolfolk. I'm a research scientist with MIMH, and I'm honored to serve as your moderator for this webinar. We will have three panelists today. They are Dr. Patricia Cavazos-Rehg from Washington University School of Medicine's Department of Psychiatry, Kelsey Hussey, the Director of Maternal and Child Health at the Missouri Hospital Association, and Clara Stevenson, the Chief Program Officer at Queen of Peace. First up, we will have Dr. Patricia Cavazos-Rehg.
Hi, everyone. I'd like to talk today about a mobile application that my team has developed. Thank you for that introduction. I'm Patty Cavazos. I'm a professor of psychiatry at Washington University. Next slide, please. So a couple of statistics just to really show you how compelling the issue is for women who are using substances and are pregnant or postpartum. Currently, what we know is that about one baby is born exposed to opiates every 19 minutes. That's really high. And also in terms of drug-related deaths, maternal mortality is 4 times higher for women who use who have opiate use disorder. And then also it's very highly likely that a death will occur oftentimes after the 1 year postpartum. So the risk is really high for death among these individuals. The costs are high. $1.5 billion are associated with issues related to opiate use during pregnancy. And then there's quite a lot of complexities that women are experiencing, especially if they have substance use disorder, in particular opiate use disorder. What we know is that there's a higher risk for polysubstance use. A lot of times levels of socioeconomic status, education levels are relatively low. There's also risks of unstable, violent living environments. Prenatal care is low. Also, there's some physical harms associated with using opioids during pregnancy and postpartum, and including fetal death and preterm labor. In addition, and this shouldn't be that much of a surprise to folks in this audience, is that the risk for discontinuing medication for opioid use disorder is really high. So discontinuation rates range from 26 to 64%. So treatment adherence is relatively low for pregnant postpartum women. Next slide, please. So what my team has done, next slide, please. So what my team has done to support the recovery of pregnant postpartum women is we've developed a mobile app. And over the last few years, we have worked with individuals throughout the St. Louis and Missouri area to help those in the recovery from opioid use disorder, and then recently expanded that to stimulant use disorder. Next slide, please. We do call this mobile app uMAT-r. We first started it out to mean medication-assisted treatment, so that was the MAT part. But now that we're expanding to other substances, uMAT-r is really to emphasize that folks mean quite a lot in MAT-r in their own recovery. And what this slide illustrates are the different features within that mobile application. As you can see here, we have educational resources, and of course, we have a lot of content about recovery, but we have other education that cover mental health issues, community support systems, content about even social supports like getting a job or how to get an identification card, things of that sort. We really communicate closely with our partner agencies to see in a comprehensive way, what education could be useful for individuals recovering from OUD or SUD. And so we have quite a lot of focus too on pregnant postpartum women and some of the unique issues that they're struggling with in this educational course feature. And I'll show you in the next slide what that looks like. But really quickly, before moving on, we also have local resources that cover all of Missouri. We like to get information all the time from our community agencies. We scan the web. So we cover about 80 to 90% of Missouri in terms of what resources are available. We have an event calendar that helps to serve as reminders for clinic appointments, medication reminders, et cetera. We also have an e-coach that communicates with users of this mobile app Monday through Friday from about 7 a.m. to 7 p.m. And these coaches are trained in motivational interviewing, crisis intervention, et cetera. And their goal is to supplement their recovery care, provide support for individuals who are engaged with our mobile app. And then we also have a goals feature that we can include any goals either from the community agency or the unique goals that the app user might have, and they let us know at the time. So we can upload the goals to fit the needs of a unique app user. Next slide, please. So this shows a little bit more in-depth information about some of the resources, the features within the mobile app. So you can see here for the resources feature, we have various organizations that the mobile app users can reach out to. If they can have content within the mobile app, so that way they don't have to go into the internet to scan for this information. And a lot of times what our coaches do is also refer the person in the mobile app to these resources and kind of works with them with whatever support that they may need and getting the resource that they need. Also, as I mentioned, the event calendar could be group sessions, therapy sessions, or OB appointments, anything that the clinic tells us or the app user, we're able to then include it into this event calendar feature. And then here's a little bit of a deeper dive into the educational lessons. We have about close to 300 now educational lessons, and a good chunk of them are focused in on issues related to pregnancy and postpartum, and especially in the context of recovery. They're mostly in PDF, kind of short layman terms. We also have video and audios so in case folks don't really want to read or scan through text, we do provide a lot of videos and audios too of the different education content. Next slide. So our team has been pretty successful with enrolling pregnant postpartum women since the COVID pandemic. In fact, we have doubled our enrollment during the pandemic. We've also become more efficient. We've reduced enrollment from 20 minutes to now it's a 5 to 8 minute enrollment. We get a lot of approval now virtually, and we're able to now obtain verbal consent. Next slide. So I wanted to really give some background information on some of the pregnant postpartum women that we have been connecting with. And this helps you to show the different characteristics of our mobile app users. And you can see that in terms of their age, the bulk of them are 25 to 34-year-old. We're getting a bit over 30% who are African American. In terms of the educational status, the majority of them have a high school education or below. Many of them are a single status. Many are unemployed. As we mentioned, there's a good chunk that have an unstable living arrangement, and et cetera. You can see down at the very bottom, in terms of the pregnancy being planned or unplanned, you can see that the majority of the women say that their pregnancy was unplanned. Next slide, please. So we've also noticed an increase in our engagement from pregnant postpartum women with you who are using our app, and this is during the pandemic. On average, in terms of the logins that we're getting per month, and this figure shows pre-pandemic versus during the pandemic. So the average number of logins have increased. The engagement with the educational lessons, we're also seeing on average, they're engaging with about 15 educational lessons per month. More with the in-app surveys, that is relatively low, and these are surveys that go out to the women daily and weekly. So on average, that has dropped a bit, and we're trying to figure out how to keep that motivation to use it, because those surveys tell us about any kind of stressors related to recovery and resources that may be needed, but they're pretty brief, maybe 3 to 5 items checking in with the participants. In terms of in-app messaging to the coach, on average, we have about 6 of those occurring per month across our participants, our women during the pandemic. Next slide. So some of the preliminary findings, we do collect data, we do interview our participants, and so I wanted to share a snapshot of some of those findings with you, and especially with this slide, this is all focused on COVID-19 and what we're seeing from our pregnant postpartum women. So in terms of the circumstances surrounding COVID-19 impacting various issues among these women's lives, you can see here that more than 50% say that the COVID-19 pandemic has impacted their recovery process. There is an increase in depression, an increase in anxiety due to COVID from most of our participants. And then also 89% of our participants do believe that the mobile app would benefit their recovery process. Related to impacts on recovery and mental health, and what are the circumstances that have changed because of COVID. So what we have, our qualitative data showing that individuals are saying that quarantine health concerns, more free time, inability to access basic needs. Other issues that are coming up are reduced access to treatment or to their medication, more problems with job loss, financial hardships, also social isolation and routine changes because of COVID-19 in the context of impacts on recovery. Next slide. So we also engage with our community participants. So these are individuals who are not pregnant postpartum women, but I wanted to share this qualitative quotes with you all so that way you can get a sense of some of the struggles that folks are dealing with. So you can see here from these various quotes, there's issues surrounding job displacement, transportation, and then this quote says, getting a job, a big part of my recovery. I need that to help me stay sober and stay busy. Also issues surrounding free time that's occurred all of a sudden, and then lack of a support group, and then also low motivation to do anything, and not feeling comfortable outside in social environment. Next slide. So some of the quotes from our pregnant postpartum women, you can see here also, and this is, we asked them about the mobile app and how much it's helping them or not. We want to get feedback always to improve the work that we do. And so some of the quotes that we're receiving from the women say, you know, they appreciate that we have someone listening and responding, and that's the e-coach. The app has helped them to get into the right mindset and help them remind them why they want to be clean. And then also you can see with this quote that somebody was experiencing some craving. Then they went to use the mobile app and they saw a message from the coach about cravings. And she says, I felt like it was meant to be. I was experiencing cravings. I didn't have anyone to call. The coach told me about some videos on mindfulness and I liked them and they really helped. So really great feedback for the use of our mobile app to support the recovery of these women. As they're very vulnerable, especially during the pregnancy and postpartum phase of their lives and in recovery. Next slide, please. And just really quickly, just so you know, I don't have much more time, but we are analyzing data and we are seeing some unique risk factors among the pregnant postpartum women with regards to MAT misconceptions and suicide attempts, and also levels of craving, et cetera. So next slide, I think this is where I end. It's my contact information. I'd be happy to, partner, meet with folks, talk to them about the potential use of this mobile app. Thank you.
Thank you. And again, if you have any questions, please use our Q&A feature on the bottom of your screen. And next up, we will have Ms. Kelsey Hussey from the Missouri Hospital Association.
Hi, thank you. I appreciate being given the opportunity to speak to everyone today. And so we'll go to the next slide and I'll tell you a little bit about the Missouri Hospital Association. For those who may not know what we do, MHA really strives to provide services to member hospital organizations and partners with various state agencies across the state. We also provide advocacy for policies that improve health and healthcare across the state and provide data really to help drive clinically based decisions to our member organizations and to others across the state too. So just a little bit about what we do and who we are. Next slide, please. And so when I was developing this, I really wanted to kind of focus on how MHA and really for our women's health programs, how we come up with our work and our scope of our work. And so we really use the Missouri PAMR report for how we come up with that. And so that's our pregnancy associated mortality review findings. And the most recent data is actually based on 2017 data. So I apologize for that typo that's up there. And so I'll just go over the highlights. You can see that motor vehicle crashes are the leading cause of injury related and then substance overdoses and poisonings are at 33%. I actually was able to see data from what will be 2018 data today, and overdoses have moved up to the leading cause at 49%. So again, we have great need for continued work with our substance use disorder and overdoses. Substance use disorders contributed to 44% of pregnancy associated and 16% of pregnancy related deaths, and mental health conditions contributed to 27% of pregnancy associated and 16% of pregnancy related deaths. And so we define those as pregnancy associated deaths are defined as the death of a woman within 1 year postpartum that is not a direct result of the pregnancy, and then pregnancy related deaths are directly attributable to a woman's pregnancy. Next slide, please. Actually, can we go back one slide? I want to just talk a little bit. Thank you. So we can obviously see that the data is telling us that there's an ongoing crisis, specifically around maternal overdose. In 2018, Missouri ranked 42nd for maternal mortality, and in 2019, we moved up to the 44th in the nation. And so we obviously are trending in the wrong direction, and that represents an increase of 42.8%. And as I just mentioned again, our overdose deaths increased to be the leading cause of injury-related deaths for 2018. So We'll go to the next slide and talk about what the PAMR's findings are. And again, this is on 2017 data. And I know that this is kind of a busy slide. And so I really just want to talk about the highlights, what the recommendations are. So they talk about, and the PAMR board is made up of physicians, from OBs, maternal fetal medicine specialists, mental health providers, social workers, trying to cover and capture the care continuum for women. And they review all of the deaths that have occurred across the year. And so they provided these recommendations to standardize practices. And when we talk about standardized practices, we know that when we have a consistent process and procedure, there's less room for error. We know that everyone then gets the same treatment, regardless of their background, regardless of their race, ethnicity, or their previous medical history. So we have launched the Missouri Neonatal Abstinence Syndrome Collaborative, which we'll talk about, and we're going to launch another collaborative, which we'll also talk about, to help standardize some of those processes. We also want to make sure that we increase the continuity of care for women. And really that's from where care starts to where care ends, and making sure that they have access to treatment throughout all of those care continuums. ACOG also recommended that postpartum care really is not one single appointment, but really is across that continuum of care. And the use of validated screening tools, again, making sure that it's not just a single question that can be asked within variation from a provider to say, how are you feeling, versus specific questions that we know have been validated and have validity behind them and are a best practice to increase those. We also need to make sure that they're used universally. And so no patients are missed and no one is stigmatized. But we also need to educate our providers and our healthcare team members really to be able to use motivational interviewing to be able to utilize these techniques and have these conversations. Sometimes we also know that in the OB setting might be the only time where a patient is with substance use disorder is going to seek care. And so we have a true obligation at this time to ensure that they're receiving non-judgmental care as well. And we have opportunities in that area as well. So, and then extend Medicaid coverage. I'm sure we are all aware of what's been going on most recently with the state legislature and the funding and with the governor on that. And so I'm not gonna talk about that, but the parent board recommended that needed to be extended. And then expand community outreach. And again, our hospitals really have an opportunity to partner better and collaborate with our community-based treatment providers and facilities, and really have a good opportunity to think about how we can partner and bridge those services with our patients too. So on the next slide, I'm going to talk about how MHA is really specifically trying to work to bring in these recommendations to the care that we are working to help our hospitals implement. So next slide, please. Okay, so when we talk about standardization, we have launched the Missouri Neonatal Abstinence Syndrome Collaborative in November of 2022. We'll talk about that here in just a minute. And then we also plan to launch the Alliance for Innovation on Maternal Health Substance Use Disorder Collaborative in August of 2021. And we'll talk about both of those here in just another minute. How we are working to increase provider education on expert and validated screening tools. So with the launch of the Missouri NAS Collaborative, we have tied that collaborative into the Mother, Infants, and NAS Echo series. And so those collaborative team members twice a month get to participate in this Echo series, which has been really dynamic. And so it has leading experts from across the state as the hub team members. So they are the kind of content experts. And then we talk about very broad topics, but it's also we also bring cases and talk about the clinical care that a patient received, what went well, what could have gone different, and how to implement that within an organization. We also talk about how best practices can also be implemented within those echoes too. And then we also have the Missouri Moms and Babies Echo that we have launched and are partnering with. And these are echoes that are open to anyone. And I'll put the links to these 2 echoes for anyone to join here after I'm done presenting. And then here in the next couple weeks, we are offering a 3-part training series with Mid-America ATTC called Embracing Pregnant and Parenting Families with Substance Use Disorder. And this is going to be offered for, again, anyone, and it is free as well. And really trying to offer a different view for healthcare workers to see and learn and to take the lens off of a healthcare worker and see, again, patients with a different lived experience and taking care of our patients in a different manner. So that's how we're working on increasing that. We also have hosted our 2nd annual NAS Summit with Department of Health and Senior Services, and that went over really well. We had 185 participants and had some follow-up meetings and conversations with other participants from our speakers as well. And then the use of SPERT and the use of validated screening tools are also part of our Missouri NAS Collaborative. Really trying to, again, get those best practices out in the hands of our providers and using those as best practices. And so we are measuring how they have been implemented in the use as part of the collaborative as well. And again, I turned my slides in last week. And so we know now that it's officially Medicaid expansion has not been funded. MHA actively has been lobbying for that expansion and for the funding of that. For community outreach, we continually engage with community resource measures as part of the Missouri NAS Collaborative. We have the Missouri Maternal Children's Action and Learning Network, where we partner with other statewide agencies to develop tools, set strategies for the overall health initiatives for mothers and infants. We recently launched a statewide resource map for providers and women, anyone to use. It's not quite ready yet. I was hoping to be able to show it to you guys today for anyone to be able to use to have available for resources for maternal substance use disorder providers for referral for treatment. And then again, we have active engagement and partnerships with community referral treatment programs, and then obviously success in program with our EPIC program. So that's just a little bit about how we have tried to implement recommendations from the PAMR's recommendations. So next slide, please. So here is our primary objectives for our Missouri NAS Collaborative, and we launched this in November of 2020. And obviously we were still in the midst of COVID, and so we thought we would, having 6 to 7 hospitals from across the state joining, that would be a win for us, and we would be greatly appreciative of that. Knowing that this is work that most hospitals have not done before. And lo and behold, we had 16 teams sign up to join and be part of this work with us. And so we were ecstatic to have that number of teams join us. And They are a wonderful group of teams working with us. One of the primary goals, as you'll see on the second one, is to use evidence-based non-pharmacological treatment to support the infant, ideally through Eat, Sleep, Console model, to foster an environment that promotes mother-infant attachment and health outcomes. And so really what we are trying to do is to decrease the number of pharmacological interventions that an infant receives. And so that's one of the primary goals. Most teams, that's a big stumbling block for them. And so they are really engaged in making that work. So in the interest of time, I'll move on to the next slide and talk briefly about our next collaborative that we're going to be launching in August. And this one is going to be changed to obstetric care for women with substance use disorder. And again, it's going to be primarily focused on mom, starting from prenatal care all the way through delivery. So we're really trying to work through the whole continuum of care from with the launch of this collaborative to the neonatal collaborative as well. So I think that's my last slide. I have resources for anyone. That's just some other information. But I have questions. You can contact me with my email, and then I have resources for the information that I shared with you guys. So if you have any questions, feel free to let me know. Thank you.
Thank you. And finally, we have Ms. Clara Stevenson from Queen of Peace.
Hi, good afternoon, everyone. My name is Clara Stevenson. I am the Chief Program Officer at Queen of Peace Center. Queen of Peace Center is one of 8 federated agencies of Catholic Charities. We are a substance use treatment facility for women and children. We are located in the heart of the Central West End at 325 North Newstead, St. Louis, Missouri, 63108. Next slide. That is my contact information. So if you have any questions, I'm available. You can reach me via office or cell or email. Next slide. Our mission at Queen of Peace Center is to break the cycle of substance use disorders for women, children, and families through family-centered behavioral health care. Next slide. We offer intake Monday through Friday from 8:30 a.m. until 3:00 p.m. at our 325 North Newstead location. We also offer virtual enrollment during those same hours by accessing https://intake.doxy.me/QOPC1. And again, Monday through Friday from 8:30 a.m. until 3:00 p.m. An individual must have a smartphone, tablet, or computer with internet access. Next slide. So the services offered at Queen of Peace Center include residential substance use treatment for up to 21 days. It is important to note that pregnant postpartum women are a priority population, so they are offered same-day access to residential treatment if assessed. We also offer outpatient substance use treatment that includes in-person groups, individual and group counseling and education, peer support, parent education, motivational enhancement therapy, cognitive behavioral therapy, same-day medication-assisted treatment, peer and recovery support services. Also at Queen of Peace Center, we offer extended residential treatment for pregnant women at our St. Philippine home. If you could please advance the slide, I think it's slide 9, where it shows the St. Philippine home. Yes. So St. Philippine Home is our maternity home, and it offers long-term residential treatment for pregnant women. It is 24 hours staffed. We have a dedicated treatment team that provides counseling, community support, and parent education. Children are able to live with their mom up to the age of 12 at our St. Philippine home. We have the capacity to serve 12 women and their children. Next slide. Can you advance it to the Our Lady of Perpetual Help? I'm sorry. And we also have Our Lady of Perpetual Help is a recovery home for women and children for women and women with children. It is accredited through the NAR Recovery Home. Women and children can reside up to 12 years of age at that home. They must also be a Queen of Peace client with a substance use disorder. I'm sorry, if you can take it back a little. Yes. So who do we serve? And this is data from our fiscal year 22. So we service individuals that are 0 and up. Our population, 28% of our population are homeless at admission. 30% of our clients did not graduate high school. 40% of clients are uninsured. 60% of clients receive Medicaid. And 63% are coexisting mental health and substance use disorder. We've noted that the primary use of substance is heroin and opiates. Next slide. Some of our key partnerships, and they are listed in no particular order, are Department of Mental Health, St. Mary's SSM-MIMH Center. We actually have a behavioral therapist that's co-located for intake assessments of women that are seeking residential treatment and even outpatient services that is embedded at the St. Mary's WISH Center. We also work with Washington University Perinatal Clinic, and we also link individuals and women to the clinic of their choice. We have partnerships with Generate Health, the Perinatal Behavioral Health Initiative, MIMH, Behavioral Health Network, Places for People, Employment Connections, Father Support Services, Center for Women in Transition, Let's Start Criminal Justice Ministry, the Lutheran Foundation. We work also with Cafe Recovery Home, Guiding Light Recovery Home, Nehemiah Recovery Home, Missouri Department of Probation and Parole, the 22nd Judicial Treatment Court Center, ARCA, Center for Life Solutions, and the Central West End Methadone Clinic, and the City of St. Louis. Next slide. Oh, that's St. Louis. So some of the questions I know that I was tasked with answering was, how does STR and SOR, how has this impacted impacted the population? So that medication first approach is essential in supporting pregnant and postpartum women and women that are not pregnant. Having access to safe housing for women and children is essential. There are times when women have to choose between seeking treatment and deciding on who could care for their child. So at Queen of Peace Center, we offer on-site child care so that is not a barrier for women. So while they're in treatment, if they're in residential, their child is in child care. We do require that all immunizations are updated. So we do have a specialized child care coordinator who assists the mom with obtaining those necessary immunizations so that the mom can be successful in treatment. Having access to treatment services is essential. And then the peer support services are also essential. And how can you as individuals that are participating in this webinar support pregnant and postpartum women with SUD? So I would encourage everyone to really recognize that each woman has a unique story and how they ended up in treatment. And I think one of the other panelists mentioned to not judge a woman seeking services because more chances are not, if they feel that they're being judged, they won't seek treatment. And at Queen of Peace Center, we recognize that although the woman is the entry point, we recognize that there are times when we have to service or we need to service the entire family. So when she seeks services, she identifies who that support system is for her. So if there's a male partner involved and he's seeking services, we have community partners that we would refer him to so that he is seeking treatment or receiving treatment at the same time as she is. And without specialized treatment for women that include childcare, women are more likely to not receive the appropriate treatment they need for recovery, which includes accessing prenatal care during pregnancy. During COVID, our challenges have included, we have seen a decrease in the number of women that were seeking treatment early on in the pandemic. We also, because of our challenges with not having like the necessary protective protection equipment, there was a period of time when our residential unit was not accessible. We still offer the outpatient services. However, we are back to full capacity. I think even today, right now, we have 16 women on the unit. But during COVID, we did notice a decrease in the number of women that were seeking treatment. Some of the successes that have been during COVID are that we had 5 substance-free births for women that were residing at our St. Philippine home. And I think the impact of telehealth and other support services on women, at the very beginning, we had to shift quickly to the telehealth providers. I think it was challenging for some women that did not have access to internet access or smartphone devices. And so that was a huge challenge. It was also challenging for women who were not in healthy or safe environments to access treatment. So telehealth did not work for everyone. So we now offer hybrid. For some, it does work. It works well for them because they're working, and so they're still needing access. And so that is the easiest way to be able to see their doctor or to be able to access their treatment team. And so there were both some successes and challenges with telehealth. Diversity and inclusion at Queen of Peace Center, we do not discriminate to anyone. We offer services to anyone seeking treatment. Our St. Philippine maternity homes embedded treatment team, the facility structures offers a unique opportunity to support positive birth outcomes for Black and Brown pregnant women who use substances. And upon enrollment in our program, linkage for prenatal care is immediately provided. I think that one of the things that are the big thing right now that's impacting pregnant postpartum women and women that are not pregnant is Medicaid expansion. So again, our slides were provided ahead of time, so we know now that this will be challenged. And so that is the thing that is crucial. The Medicaid expansion is needed. It is noted that after about 6 months, and when women lose their Medicaid, they stop seeking treatment, and that is especially noted for those women that are receiving methadone. So I think Medicaid expansion is crucial with this population. So I know I went pretty fast. So again, if you have questions for me, my contact information will be provided in the slide that's available. And that's all that I have.
Thank you. And now we're going to move on to our question and answer period. And again, if you have any questions, please use our Q&A feature at the bottom of your screen. You can submit them anonymously, and you can also upvote questions that are important to you. So we had a few that were answered already, but Dr. Cavazos, can you speak a little bit about, there was one question that you answered. For programs that include text messaging, could you provide some discussion regarding HIPAA and how to address that?
Mm-hmm. Yeah, so the mobile app is HIPAA approved, and we are being monitored by our IRB at WashU. So, those issues are covered. We do request BAAs, business associates agreements, with all of our community partners. And that also is paperwork to cover, data sharing and things of that sort across both parties, us at WashU and the community partners. And then also one other thing that we do is if there's concerning content or concerning text messages, if we find out that there's a risk for relapse or any kind of suicidal ideation, we do let the counselors know about this. So we work pretty closely with the community partners to let them know when, concerning issues are brought up. And so, that was also something important to mention. We do let the clients know that this is part of our protocol too. So, it's not that it's a surprise that we're communicating with the counselor. We let the clients know ahead of time that, if there is any harm to themselves or to others, we are going to reach out to the counselors and let them know that that this has been uncovered in the mobile app. And surprisingly, we get a lot of concerning content posted in the mobile app. So, people are comfortable on their phones, they're comfortable with texting. So we do find out information like that. So I just kind of want to also put that out there too. So it is important to have the paperwork in place and for us to be, HIPAA approved, which we are.
Thank you. And the next question is for Queen of Peace and uMAT-r. Do you hear different objections to MAT among pregnant women than you do among people who are not pregnant?
Can you repeat that?
Do you hear different objections to MAT among pregnant women than you do among people who are not pregnant?
I don't know that we've really encountered women who are opposed to MAT. I think when they present to Queen of Peace Center, they are seeking assistance for medication.
Yeah, and I'll add a bit to that because we actually did survey our participants about misconceptions related to MAT. And so what we found is for the pregnant postpartum women, unfortunately, a lot of them don't believe that MAT is safe for them throughout their pregnancy. And also there is this misconception that the more MAT that a person takes, the more chances the baby's going to have neonatal abstinence syndrome. So that's a misconception that we need to target. And then also there's this belief that they don't need MAT after birth. So it's kind of really concerning things that we have identified in the survey, and we're hoping to move this forward to a peer review publication. But we are finding at least those misconceptions that were expressed among our participants.
And I'll just add to that, those are things that we are also hearing from our collaborative teams as they're working with moms on the labor and delivery side and prenatal clinic and postpartum side too. And so we are also working on the hospital side to try to engage moms in the prenatal side to continue their MAT and to stress the importance to continue after delivery as well, and provide education, that it's safer to continue on their MAT during pregnancy, and even especially and not just stop taking and have non-assisted MAT withdrawal and have that affect the infant. For sure. So we're seeing that as well, and providing education even on the provider side to our teams as well.
Thank you. And our next question is for Clara Stevenson. If all of your sites are full, what do you do with new members who might need housing? Do you have any options?
So we do have partnerships with other recovery homes. So I mentioned in our partnerships, so Nehemiah, so we have a standing MOU to place clients at Nehemiah Recovery Home, at Cafe Recovery Home, and also Guiding Light Recovery Home. And so we do work with other providers for housing. And so it really is client choice as well.
And the next question is for everyone. Do any of you have any pointers or of items to start with first and foremost when beginning to break the stigma in a family practice clinic?
Yeah, so I guess I'll go ahead, Claire. No, Claire.
So I was just going to, so I always like, we require that we start with our values of hope, dignity, and respect. And so when the woman walks through the door, it has to be with, recognizing that, whatever I say or, whatever, like all of my thoughts go out the door. I have to approach her with having hope, dignity, and respect. So that's where it starts, because again, her story is unique and she's not, she's walking through our door because she wants us to help her. And so we start with our values, and I think it goes up, it's helpful from just, relying on our values of hope, dignity, and respect. And that's from every employee that works at Queen of Peace Center.
Yeah, I'll just add in, I think I'll say it's an opportunity in the healthcare field in general as well, especially for a pregnant woman. I would argue that a pregnant woman with substance use disorder is probably the most stigmatized person that there is. And so what we have really tried to do with our collaborative is to provide training and teaching, and really coming from a place and perspective of everyone has a lived experience, and there are background pieces that we have to come to understand. And starting with a foundation of substance use disorder is a chronic medical disease, just like diabetes and just like hypertension. And it's a disease that is treatable and with medication, and we have an opportunity and an obligation to treat it as such. And then coming back to the stigma piece is that we know that people with past experiences with trauma and past experiences in their life that a lot of people don't have also influence the impact that they have with substance use disorder. And so coming and reminding to those perspectives has been helpful. For some of our teams and for some of our physicians, and they're hard conversations, and it takes a lot, and it's an education piece. And so I just put in the chat for everyone the 3-part training series that we're putting together with Mid-America ATTC. You have to register for each one of those training series individually, but really trying to break it down into those 3 kind of different components. And so I welcome all of you guys to join, to share that link out to your colleagues and to your friends as well.
And I just want to add a little bit to that, and because we did also ask our participants about various treatment barriers that they had, and including financial concerns, transportation, access, trust with provider, and the highest one was stigma. And it's very concerning and surprising, and it is a modifiable factor that we can address. We have to do better, and so I really commend Clara and Kelsey for the recommendations they have. On our end, what we're trying to do is really get to understand what this means to the users, and we have a whole grant that's just going to be focused on stigma among pregnant postpartum women with opioid use disorder. Hopefully that gets funded, and what we're going to do is do a lot of user-centered focus groups and figure out what we can do, at least with the mobile app, to help address these issues and to support what is happening with our clinical partners in addressing stigma, because it's very real and it's modifiable, and we can do better.
Okay.
Yeah, we have to do better, Patty. We have to.
And our next question, I believe this is regarding Queen of Peace, I believe. Do you feel that there's more judgment or stigma amongst your staff of pregnant people who use drugs than non-pregnant people?
I would hope not. And we allow clients to voice like any concerns if they're feeling, that they're being judged. But our goal with hiring individuals, and because we have a huge impact on a woman staying in recovery and having substance-free births. And so it is not our goal to have people on our staff that don't believe that recovery is possible. So our mission, we're true to our mission. We want to break the cycle of substance use.
And next question is for everyone. I work with people who use drugs and pregnant women who use drugs. They are afraid to go to the doctors because of their drug use. What would you suggest to a woman who is about to give birth but is terrified that their baby will be taken away when the mom gives birth?
I think, you know, if they don't seek treatment, there's a chance that they will, I mean, they could die. I mean, it's concern. I mean, yeah, it would be concerning to, I think the earlier that they start prenatal care, the better. I know that for hospitals, any woman that has a history of substance use disorder or even, you know, taking MAT, they are required to, they're a mandated reporter. So, I mean, you can't really avoid that. I would say the peer support, and I know that I didn't stress that a lot, but the peer support specialists that we have in our agencies are so important because they have that lived experience. So I think the peer support, having peer supports to have that first kind of like contact at the beginning is so crucial because their lens is different than others. And so they have a way of engaging the woman for treatment. And so if you have the ability to have peer supports in your agency, that really it's crucial. We can't exist without peer supports.
And I think I would add, you know, a lot of what also we find out is that there is a lack of understanding about recovery options and, you know, the efficacy of the medication, what resources are available, and, you know, basically that recovery works, right? I mean, I think that treatment works. And so really motivating, you know, the woman to get into treatment and get some help, start medication. You know, these are the side effects you should expect. This is the truth about the medication and how it works. I mean, so really kind of informing the woman about her options for recovery. I think that's a big thing. It's surprising how much of a difference that can make to help motivate someone to try it out and start their pathway to recovery. Yeah, I mean, I think we just need to really provide that education, and it's available, but we need to we need to engage with the folks to give them that education, and it can happen and make a difference.
Yeah, and I would just add, you know, if a woman is wanting to seek recovery, then this is an opportune time for her to seek recovery. And, you know, I think that some of our work has been working with the Children's Division, and I know that it's very different in different parts of the state, and they are really working hard to try to change how that is working and is perceived, but really trying not to, the goal is not to take a child away from a mom. And so if a mom is engaged and actively engaged in seeking treatment and engaged in their recovery, that absolutely goes a long way. And so I think, you know, to help answer that question, you know, there are some pieces that healthcare providers are engaged with. And so different hospitals have different policies on what they are required to do and to report, but the engagement of a mom and again, with that peer specialist being an active supporter and kind of talking through and what to expect, I think is the best place to start, as Clara mentioned.
Thank you so much, everyone. We're a couple minutes over, so we do need to say goodbye. This was a wonderful discussion. Thank you to our panelists and to our moderator, Candice. We just got into some juicy stuff right at the end there about drug testing and mandatory reporting during pregnancy and upon childbirth, and working with the Children's Division. So I think many of us would be interested in picking up this conversation from an advocacy angle, because Christy Booth is absolutely right. No one should have to choose between seeking recovery and worrying about getting their child taken away. But that is absolutely a very real fear. And I think between the people on this call and the people attending, we have some power to make some change there in Missouri. So thanks again, everyone. I'm gonna wrap it up and say goodbye. Thank you for attending. Happy Friday.